Welcome everyone, I'm Najla Nasri from Johns Hopkins and I'll be moderating the Journal Club session. Today we're fortunate to have Dr. Nicole Dubosh presenting her newly published manuscript called Missed Serious Neurologic Conditions in Emergency Department Patients Discharged with Nonspecific Diagnoses of Headache or Back Pain. It'll be a great session, so thank you all for joining us. So now we'll transition to the presentation portion of the session. I'm pleased to introduce Dr. Nicole Dubosh. She is an assistant professor of emergency medicine at Harvard Medical School, and she serves as the associate director of the emergency medicine clerkship and the medical education fellowship at Beth Israel Deaconess. In addition to medical education, her research interests include neurological emergencies and specifically misdiagnosis. Dr. Dubosh has lectured nationally and internationally and has numerous publications on these topics, and she has received grant funding for her medical education research. Welcome, Dr. Dubosh, and thank you for presenting today. We will now turn it over to you.
Thank you. Thank you for having me. So a little bit of background, and hopefully you all had access to my article and were able to read it beforehand. I'm just going to summarize briefly our methodology and some of the key findings and implications from this study. So a little bit of background, we know that misdiagnosis has many consequences on various levels. On the public health and patient level, misdiagnosis can lead to a significant amount of morbidity and mortality, which can then in turn lead to readmissions, increased resource utilization, and increased financial implications. Now, the diagnostic error rate ranges by diagnosis and by study, but in the ED patient population, this has been cited from anywhere from less than 1% in some studies to up to 35%. So we don't really know the true rate, and more importantly, we don't know the incidence of misdiagnosis-related harm, which that's actually what we're caring about as clinicians on the individual patient level. So in this study, we chose to focus on neurological emergencies, one, because it's a particular research interest of mine, but also because many neurological diseases have time-sensitive diagnostic and treatment implications. There have been some small studies that have used various methodology of studying misdiagnosis, but the incidence, risk factors, and diseases of misdiagnosis-related harm still remain unknown. So we sought to estimate the incidence of misdiagnosis-related harm using big data. The goals of the study were twofold. One, we wanted to describe the likelihood of ED visit or in-hospital death for a serious neurological condition for patients who are discharged from the emergency department with a nonspecific diagnosis of headache or back pain. And then second, we aimed to identify the specific missed conditions and the risk factors for these. So this was a retrospective analysis. We used the Healthcare Cost and Utilization Project databases. For those of you not familiar with the Healthcare Cost and Utilization Project, this is a family of healthcare databases that was developed through a federal, state, and industry partnership, and it's sponsored by the Agency for Healthcare Research and Quality, or AHRQ. And this is actually the largest data set of hospital care in the United States. So we specifically looked at two of these databases within this project, the state emergency department databases and the state inpatient databases. And we selected 6 states given their geographic variability and included these in our analysis. So during the study period, which spanned 6 years, we selected patients who were greater than 18 years of age, who had a treat and release to home or non-acute care discharged from the emergency department and were discharged with a nonspecific headache or back pain diagnosis. We excluded trauma patients, those who left the emergency department against medical advice, those who died in the ED, and out-of-state residents. And this last one was because we weren't able to follow up those people who may have represented in another state. So this is a list of the diagnoses from ICD-9 codes that we sought to study. For headache, we chose tension headache, migraine, acute headache, head pain. These are all non-specific diagnoses that are commonly put on ED charts on discharged patients. And likewise, for back pain, you can see on the right here the list that we chose for similar reasons. So in our methodology, we use something called the symptom disease pair analysis of diagnostic error, or the SPADE approach. So this is a conceptual framework that's been described in the literature for studying misdiagnosis-related harm in large data sets. So when you think about investigating misdiagnosis, there are two ways to look at this. There's the look back approach and there's the look forward approach. The look back approach is when you take the diagnosis and then you go back and look at the symptoms that may have brought the patient to the healthcare setting in the first place. The look forward approach is where you take the symptoms and look forward at the diseases that may have been missed. And we went with the look forward approach in our study. Our main outcome measure was return ED visit and hospitalization for a primary diagnosis of a serious neurological condition or in-hospital death within 30 days of the index ED visit. And if you have the paper in front of you, you can see this list of diagnoses in Table 1. We specifically chose these because these are thought to be emergent diagnoses that have time-sensitive diagnostic and treatment implications, and if missed, will lead to significant morbidity and mortality. In our secondary outcomes, we looked at these return visits and hospitalization at 3 days and at 7 days. And then finally, we looked at a control group for non-neurologic chief complaints, including cough, chest pain, abdominal pain, and soft tissue infection, just to make sure that we were actually seeing this wasn't all background and that we actually were seeing an effect. So again, we sought to calculate the incidence of outcome for each of these groups for headache and back pain. And we performed a multivariate logistic regression for several demographic features, including age, sex, race and ethnicity, primary insurance, quartiles for income, urban or rural status in terms of the hospital, comorbidity, states, season, and year. Then we looked at the 10 most frequent diagnoses by ICD-9 code and by AHRQ clinical classifications to determine those diagnoses that were most frequently missed. So in terms of our results, for patients with a nonspecific discharge diagnosis of headache, we had over 2 million. And for those with a nonspecific discharge diagnosis of back pain, we had over 1 million. In terms of our main results, for the primary outcome, we found that the rate of misdiagnosis-related harm was 0.5%. And for back pain, this was 0.2%. And you can see the numbers here, and you can see the main results in Table 2. We also found that the frequency of the outcome was highest on days 1 through 3. If you look at figures A and B, you can see that this drops off significantly after day 3. We also found that the control groups had a lower incidence. You can see this on Table 4. In terms of headache, we found that there were several demographic features associated with a higher misdiagnosis-related harm rate. Similar for back pain, these included older age, male, non-Hispanic white, several comorbidities, including neurological disorders, HIV, malignancy, substance abuse for back pain. And you can see here for headache, we've listed in Table 5 those top 10 diagnoses. So within 30 days, you can see that CVA was the most common misdiagnosis, followed by, nonspecific other cerebral ischemia, subarachnoid hemorrhage. In terms of back pain, intraspinal abscess, which includes epidural abscess, and cauda equina syndrome were the most frequently missed conditions. So there are several limitations to our study. One, this is using administrative data, which can be prone to errors. The Healthcare Cost and Utilization Project, though, has been well researched and has actually shown to be valid in a number of other studies. So we think that it is possible that we have underestimated this rate given that. Second, large databases fail to capture events for other states, and specifically this database, and for out-of-hospital deaths. Third, we are using the assumption that the return ED visit is a marker of misdiagnosis-related harm. Again, this data is not very granular, but we do have large numbers, and similar studies have used this methodology previously as a way to estimate misdiagnosis-related harm. And then finally, we are looking at correlations, and it's hard to say if this is actually a cause, if the first visit was actually related to the second one, which we are then presuming resulted in misdiagnosis-related harm. So again, we found that a small proportion of misdiagnosis-related harm occurred in these patients discharged with these nonspecific symptoms. We found a 2 times greater rate for headache compared to the back pain patients. And this is the first population-based study looking specifically at neurologic diagnoses and estimating the misdiagnosis-related harm incidence. And what was interesting, compared to some of the other studies out there looking at misdiagnoses, specifically in neurological emergencies, we did find a lower incidence compared to the other studies. So one of the reasons I think for this is that we used this look forward approach. And one way to kind of conceptualize this and think about it is to think about a needle in a haystack analogy. So in this look forward approach, we took the haystack and we went and sought out those needles or those specific diagnoses that were missed. Prior work in the misdiagnosis area has looked at the specific diagnosis using a look back approach, which is when you look at that pile of needles and then you go back and you try and figure out those symptoms that led, or the presenting features that led to that misdiagnosis. So in conclusion, we found that a small but significant proportion of patients returned with serious neurological outcome or an in-hospital death after ED discharge with a nonspecific diagnosis of headache or back pain. Ischemic stroke and intraspinal abscesses were the most common misdiagnoses, and we also were able to identify some of the risk factors for misdiagnosis-related harm. Thank you. And at this point, I'll turn it over to the group for any questions or further discussion points.
Great. Thank you, Nicole. So we'll open it up to the audience, and you can feel free to use your mic or to type in any questions or comments in the chat box.
Hi there, this is Rob Elcara from UCSD. Thank you for the presentation. That's really interesting work. And I particularly like the distinction you're making between the forward-looking and backward-looking one, because obviously that comes up, like you said, with very different numbers. From an emergency medicine standpoint, were there any results in particular that kind of stood out as unexpected or surprising to you in terms of either the types of diagnosis or that were subsequently found, or the frequency or anything like that?
You know, I was actually surprised by the low incidence rate that we found. You know, a lot of times there's a lot of focus in emergency medicine, especially on these high-risk diagnoses like stroke and cord compression and cauda equina, that we are missing a lot. You know, when you think about litigation cases, these are some of those really high-risk and more frequent diagnoses. So I assumed that we were actually, you know, doing a lot worse job than we are. And I was surprised that the rate was so low. When you consider the numbers, you know, you extrapolate this out, we had over 2 million and over 1 million patients, you extrapolate it out, there are significant numbers. But again, overall, thinking about some of those other diagnoses and what our testing threshold is and acceptable miss rate is in emergency medicine, this was actually pretty low, which suggests we are doing a decent job.
Great, thank you.
This is David Newman-Toker. Great work and lovely presentation. I'll make a comment and then ask a question. So on the issue of you know, the low rates, these are exactly aligned with the previously published literature. There have been look-forward analyses previously done in Ontario, done in California, and other places, and these numbers are pretty typical. We see things, you know, on the order of magnitude of 0.2% up to 1% of patients with an unselected, neurological complaint, dizziness, headache kind of stuff, come back roughly with some sort of second admission or event. And it does translate to lots of people, like tens of thousands of people. So it's the perspective on whether it's a low rate or not is really a function of, if you take it through the public health lens, it's an enormous number of people. And if you take it from, the total number of people that die from missed strokes every year probably, or are permanently disabled as a consequence of missed strokes every year, is probably similar to the number of people that die from breast cancer each year. A little higher maybe. So it's a non-trivial issue. The second thing is that just on the methodology, I'm just curious how you dealt with your decision making around which non-specific complaints to look at. I noticed you chose migraine and tension type headache, but you didn't choose, cluster headache or other headaches within the ICD-9 coding structure. What was your methodology for sort of thinking about what codes you were going to use for people to define your denominator for your cohort?
Yeah, we wanted to be kind of as vague as possible of symptoms, meaning, when you get into these details of cluster headache, again, those ones are actually very, very uncommon in terms of ED discharge diagnosis. We wanted to keep it, looking just at headache. The only one we did choose to include was migraine, because a lot of times, and that's one area where I think there is a lot of misdiagnoses. A lot of times people are discharged with a diagnosis of migraine. In fact, it's not when they come back. And we didn't find much of a difference when we looked at migraine versus just headache or head pain. But we wanted to keep it as non-specific as possible. And that's why we didn't include some of those other more specific ones.
So just as a quick follow-up question, did you do any sort of exploratory analysis looking at the larger set of codes? I mean, you went to the trouble of doing the CCS coding structure. Mm-hmm. Did you delve into the other codes that within CCS are coded as headache or back pain to see what their relative frequency is? I'm sure you're right that if you look just at all the HCAP data and said, okay, what are the top diagnoses within the CCS headache bucket? Migraine, tension headache, and just headache not otherwise specified are almost certainly going to be the top three. I'm just curious whether you did any sort of look to see how many others there were. In other words, is it possible that we're missing a non-trivial number, and that 2 point however many million you said for headaches, 2.1 million is actually 3 million if you count all the rest of the codes, or is it more likely 2.15 million?
Yeah, we did not do any sort of preliminary exploratory analysis on that. That would certainly be interesting to see, if there was a significant number of those.
Okay, great, thank you.
Hi, this is Chuck Pilcher. Can you hear me?
Yes,
yep.
We can.
Okay. I like the look forward approach, but I'm curious to know if you did the look back approach, and particularly with regard to spinal epidural abscess, what percentage of people who have a spinal epidural abscess had it missed on the first opportunity to make the diagnosis? And that would require a look back approach.
Yeah, we did not do this in this particular analysis. We only stuck with the look forward, but I think that would be a really interesting study to do, a future research idea with this data set.
The reason I ask is that I do a lot of medical malpractice review and have seen like 15 cases of missed spinal epidural abscess. And the key to the diagnosis is to think about it as whenever you have somebody who's presenting with unusual back pain, especially with the risk factors you presented in your tables.
Mm-hmm. Yeah, I think that would be really interesting to look at on a large scale like this.
Nicole, I have sort of a question sort of related to what David asked, but I was just curious if there was any sort of standardized approach to picking the control groups that you did. And the reason I ask that is just because on table 4, it does show that rates are lower in the control groups, but if you sort of look at the confidence intervals, there's a good amount of overlap in the confidence intervals with the group or the group of interest. So I'm not sure if the study was powered to be able to detect a difference, but those confidence intervals suggest that maybe the control group wasn't too different from the comparator group.
Yeah, and so we consulted with our statistician and some of the other co-investigators on this study who have done a lot of work using the HCUP database previously. And it was, they recommended, we initially thought we'll just do one. Other studies have looked at things like shortness of breath when it comes to, looking at neurological misdiagnoses and using control groups. We chose to do 4 just to make sure that it wasn't, just by chance that we were seeing a similar rate or an increased rate. And again, I think with these, there is overlap in the confidence intervals. And I think with these really low incidences of outcomes that we saw in our study, it's not unexpected that you are going to see that, because there is going to be a lot of that background noise where patients come back. And again, like I said before, we're using this return ED visit and hospitalization or in a hospital death as a marker to measure misdiagnosis related harm.
So this is sorry, go ahead.
Oh, no, go ahead.
No, follow up, Najla, and then I'll ask.
Oh, no, my question was I was just curious if you were to think of, is there any ways in downstream that you could do either a related project or expand on this one that would be able to sort of tease out the signal from noise a little bit more?
Yeah, and I've kind of thought about that. I'm not really sure the best approach. I think, looking at more at a granular level and actually being able to look into the chart, because that is one of the limitations with this large database. You can't actually look at the chart, see what really happened, see what those diagnoses were, causes of death, ultimately in those patients who were hospitalized or died in hospital, and see if there are any other factors contributing. A lot of times patients come back and they have multiple other inpatient diagnoses.
Right.
So I think being able to tease that out would be really critical, both in terms of seeing if these, if this is really just background noise or if there is an effect, and also for us as clinicians in order to better understand the factors contributing to misdiagnosis and coming up with ways to improve that.
This is John Healy. Are you able to hear me?
Yes, we can.
I had a question having to do with a couple of possibilities. One is that someone came in with a headache that was, say, typical for migraine, and would have been impossible prospectively to suspect, or let's say unreasonable to suspect a more serious diagnosis such as a stroke. And so prospectively there was no fault. Or the other possibility is that somebody could come in with a tension headache, and they really did have a tension headache, and then a totally different disease process took over a day later, and they had a stroke. And the headache wasn't really a warning of a stroke, which I suppose it wouldn't be anyway usually, but it was 2 different diseases. And will the control group control for that kind of issue?
Yeah, that's precisely why we used a control group, because in any large sample of patients, you're going to have people who come to the emergency department twice within a 30-day time period. And whether or not the visits are related is kind of, we can't really discern that from this type of analysis with this big data. So that's why we did a control group, just to see kind of what that background noise was.
Okay, thank you.
This is David Newman-Toker again. Just on the control group issue, did you guys consider doing a control outcome condition in the same cohort rather than a comparison cohort?
Say that again?
Did you consider looking at a different disease outcome in the same cohort? So headache patients looking at the rate of MI returns within 30 days rather than a cohort, a different cohort.
Okay, we did not. I think that would be, we initially, when we were doing this paper, we didn't include a control group initially. We wanted to purely just look at this incidence. We added this in and did this analysis at the request of the reviewers on our revise and resubmit. Sure. But that would actually be really interesting. If it's, I would anticipate it would be the same, but again, I don't know about any study. Pardon?
Yeah, we've done stuff like that. So so for instance, the Kim study from UCSF in the California OSHPA data looked at the cohort of patients discharged with benign dizziness, or so-called benign dizziness. They looked at the rate of return for patients who came back with stroke, but they also used a comparison outcome of MIs in the same patients discharged with dizziness. And you can see the clear difference between the stroke returns and the MI returns. We've done the same thing. Nodula's helped lead some of that work with us. We've been doing that using Kaiser Permanente data and the look forward method. We've seen the same thing. And we've done it using the look back, where we've compared different symptoms in patients diagnosed with the same disease. I actually think that that's a stronger model for thinking about comparators in this context than having a separate cohort. In other words, what does it say to you that, patients with chest pain do come back with strokes? Well, maybe patients with chest pain have AFib, maybe they have MIs, they have other things, and those things are risk factors for stroke. Not necessarily a great surprise that they would come back with strokes at some increased risk in the short term. So it's not a clean control group in that sense. Whereas if you just do a comparison outcome where you look at both the rate of return for stroke and the rate of return for some disease that you suspect is unrelated to headache, then, deep vein thrombosis or PE or some, MI with the rare exception of the the so-called headache due to angina patients, but essentially that gives you a better window into differentiating whether it's a real effect or just a sort of an illness related effect.
Right, that's a great point. We did not do that, but I would be really interested to see that in this population.
So what's your next step?
I think the next step, I think me in particular, I like neurological diagnoses. I like medical education. I would love to come up with ways to teach learners and trainees and, practicing clinicians ways to think about the factors that lead to misdiagnosis in their day-to-day, medical decision-making, clinical care in order to decrease this further. And I think, I've done some work with others at my institution looking at, recognizing factors like cognitive errors and biases that play a role, particularly in the emergency department, where you have kind of a lot working against you at times when it's busy workflow, large volumes of patients, which just is the perfect setup for using these cognitive biases and leading to misdiagnosis. So I'm interested in looking at ways in order to bring this to everyone's attention. And again, it's hard to always be cognizant of this in your day-to-day patient care. But I think it's really important, and that's kind of where my interest lays.
I really
you
like
for
what
sharing.
you mentioned in the discussion section how, lots of people can sort of help with this unconscious bias, and it can go down to the, the radiologist putting in their report, MRI report saying, we do not see anything, but 7% of, MRI reports may miss a posterior stroke. So just sort of different things that we can include into the work stream that may help the providers on the front lines just sort of reconsider what they're diagnosing.
Yeah, and I think, even implementing using decision support methods or building something into the EMR where it's going to alert you with certain patients who come in, with the non-specific back pain, where you have something, flashing up, they do have a history of substance abuse, they are older, and just reminders, because we know some of these people who are more at risk, older patients. Because again, a lot of that, it should be second nature when you're getting your history, reviewing the chart, but oftentimes I think some of these risk factors aren't initially noticed.
Is there someone else that had a comment or a question? Nicole, is there also one thing that I was curious is there also any reason to think that, the rate was so low because these specific states have really good infrastructure in place? I know you chose these 6 because they had the best sort of linkage throughout the years, but do we know anything about how they sort of perform also relative to other states?
And again, some of the co-investigators have done a lot of work with these databases before, and they recommended using these because there was geographic variability and diversity, and there was these ones in particular in this database have pretty high data quality and had the best follow-up.
Mm-hmm.
I think for those of you who don't know the article, we chose California, Florida, Iowa, Nebraska, New York, and Utah.
What opportunities do we have to identify the primary reasons why these diagnoses were being missed and learning from the results of your study?
Yeah, so I think it's tough. I think from this data, which is not very granular, it's hard to say why these were missed. If you read in the misdiagnosis literature, there's a lot of different factors that play a role in all of misdiagnosis, right? There's the system-based factors, there's the cognitive errors that play a role, there are knowledge gaps, not understanding the limitations of certain tests. For example, an MRI, an early posterior circulation stroke, assuming a test is negative does not always rule out the diagnoses. So I think, coming up with ways to research this further and really get at those reasons is critical in terms of, further decreasing misdiagnosis and misdiagnosis related harm.
There isn't a way of getting access to the actual charts of the patients you used in your study so that a more granular approach could be researched.
Yeah, in this particular study, unfortunately, we could not.
This is Rob Elkera, just to kind of touch on some of the stuff that we've done just to that very point. I think it's more of kind of the idea of like at your local institution being able to get that granular data. And I think in large part being able to communicate with the team in a relatively near real-time manner, I think is key to that, because a lot of the nuance about what exactly happened is not necessarily captured well, even if you did have access to the chart, in the sense that a lot of the decision making is not really documented that well. And so things like, potentially trigger-based case review where if you have somebody that came back to the hospital with one of these diagnoses, being able to maybe touch base with the primary team and discuss it a little bit would be very helpful. Granted, the numbers I know at any individual location are not that huge, but if you have several different outcomes that you're looking at, it may show some common themes as to particular, I guess, issues around decision making or information flow or something like that.
Yeah, I actually did a smaller scale study a few years back, published in Diagnoses, looking at missed neurological emergencies at our institution. My department has a pretty robust QA system where there's a weekly QA meeting, the cases are discussed, the providers involved in the care have to actually kind of give a narrative about what their thinking was in terms of these misdiagnoses. So we looked at those meeting minutes retrospectively from our weekly QA minutes to try and discern the different types of errors that play a role. And we saw, this missed stroke was a, systems-based issue. It was not on the part of the ED provider. It was that there was a radiology misread. The resident radiologist who was on overnight read the study as negative. It was overread the next day. Patient called back, and it actually did have a finding type thing. So we've tried to do that. Again, it's hard to do that on a large scale because it involves going into the individual chart and actually talking with the providers if the medical decision making in the record is sparse. But I think that's, that will lead us to conclusions about why these things occur.
We have a couple questions in the chat. The first one is, you mentioned wanting to teach learners about this type of misdiagnosis. Is there anything that you think patients could do to improve the issue as well, aside from giving their full patient history, or does it preliminarily fall on the clinician?
I mean, I personally, unless you have a patient who is very well versed medically, I don't think patients are going to be able to know. I don't think we can put it on them and telling us what's important and identifying those risk factors on their own. I think you think about your typical patient you see in the ED, I think most of them are at that, what we say, the 6th grade health literacy level. And again, I'm sure we've all had those patients who come in and they said, I've Googled this, I think this is my diagnosis. And in fact, at times they are correct. But I think overall, this is more on the clinician, and it's on us, and it's on our system and our systems we have in place at the healthcare level, not on the patient. I don't know if anyone else has a different opinion on that.
We have,
Well,
oh, go ahead, David, and then I'll read the next question.
I'll answer that question. I think we actually probably, not that we want to place all the burden on the patients, but I think empowering patients to know more and question more, especially with situations that are pretty common. Next month we'll be releasing some work that shows that half of all the serious harms from diagnostic errors are accounted for by just 15 diseases. And most of those are accounted for by a relatively modest number of presentations that get missed. With stroke, at least half of the missed strokes are missed dizzy patients, missed headaches, and, a couple of other things, a little numbness here and a syncope there, but there really aren't a ton of problems. So you think, okay, look, what are the things in a patient with headache that the patient needs to be worried about and the doctor needs to be worried about? I think empowering patients to know some of the facts about headache and stroke and know some of the facts about headache and meningitis and a couple of other things, I think is probably not a bad idea and something that could potentially benefit, since it's so difficult to get the entire healthcare system and the entire medical education system and the entire electronic health record system to move. But patients have kind of a vested interest in this. So I think if you could tap into that motivation, there might be some potential.
And we have one other question that says, I noted that migraines versus non-migraine diagnoses led to a lower incidence and errors. Can you comment on this?
Yeah, so I think, both of these had a pretty small rate. The non-migraines was lower. And again, I think this was an interesting finding. I don't know what to make of it. Me personally, when I discharge a patient with a nonspecific headache, even if it sounds like a migraine, I never put the diagnosis of migraine because I tell patients, this is something that needs to be, you've had to have multiple incidences of this, brain imaging, have a diagnosis by a neurologist. But again, I think just in terms of sheer numbers, though, we do see a lot of patients with a known diagnosis of migraine who come into the emergency department with their typical migraine, get treated, get discharged, and in fact, at the end of the day, it was a migraine. So that could be why.
We have one other question also. It says, any particular factors that you think we as teachers tend to miss or underestimate when we teach red flags for headache or back pain from your findings? Also, I'm curious if some centers do have something like follow-up clinics run by hospitalists, for instance, for this potential serious presentations.
Yeah, so I think just kind of anecdotally from my experience, I think one of the things that we often fail to understand is the limitations of radiology studies. You have a patient who comes in with a thunderclap headache and you get a CAT scan and there's no subarachnoid hemorrhage, failing to actually complete that workup and realize that, the non-con CT is not 100% sensitive. You need to consider that timing and whether or not the patient needs a lumbar puncture. Same with MRI for strokes, especially those posterior circulation strokes. We actually, my medical center does have a neurology urgent care follow-up clinic where we can refer patients, which is great. It would be interesting. I haven't looked at the data showing if any of those patients return in clinic with a misdiagnosis. And presumably they would be referred back to the ED for admission if it was something, serious in terms of those diagnoses we consider in this study. But I know not most hospitals, especially community sites, don't have those clinics readily available.
Do we have any other questions or comments for Dr. Dubosh? Okay, so I think we come to the end of our time. Thank you so much, Nicole, for presenting today and for everyone for joining us. Our next journal club is scheduled for August 13th, so we hope to see you all there. And if you do have any recommendations for articles or investigators that we should reach out to, please send them our way.